Great, welcome everyone. It's my pleasure to introduce Joanne Steckler, who's in our Division of Allergy and Infectious Disease. She's an assistant professor and the Deputy Director of Public Health Seattle King County HIV and STD program. We're really lucky to have her. It's nice, you know you picked the right speaker when some of the articles she's going to cite are her own to do with the topic of HIV testing. So Joanne, take it away.
Thank you very much. So basically there are three things that I want you to get out of the next 15 minutes. The first is the idea that we've changed so that we are now trying to expand HIV screening, and that we'll be talking about routine HIV screening for everyone. I want you to know that there are different HIV tests at your disposal, and in the next year or two that there are going to be a bunch of changes both in testing and in algorithms and how we're using these tests. So that's what we're going to be talking about in the next 15 minutes. So let's move into routine HIV screening. So some of you may know that in 2006 the CDC recommended that everyone who touches healthcare should get HIV tested regardless of their risk factors. So these are the bullet points from the report that came out in 2006 saying that all patients 13 to 64 who are in these primary care and urgent care settings should get at least one HIV test in their life, and more frequent testing if they have risk factors. There's a move towards more voluntary testing that is separate from consent, should be separate from the, that consent should no longer be a separate consent, it should be part of the general consent for care, and that there's no longer this need for the checklist that we all trained on how to reduce risk. So really testing and counseling about HIV prevention should be separate. So I just wanted to spend a little bit of time talking about why this change was made. The first is that although we've done a great job of getting our patients who are most at risk tested, that we're still in general diagnosing people too late in infection. What this slide shows is the median CD4 count at the time of diagnosis among a cohort of patients who are newly diagnosed with HIV. And what you can see is that although the CD4 count has been rising, meaning we're catching people sooner in infection, that we are currently in the 300s, which is still well below the recommendation for when we should be starting treatment for HIV therapy. A little bit more support is that the sooner you catch people, the higher their CD4 counts. When you start therapy, the better their immune system responds. So we want to catch people early. We want to get people on antiretroviral therapy early before there's been a lot of immune system damage. Finally, although we've done a decent job of getting our targeted testing into our highest risk groups, that we know that targeted testing misses people. And we know this because what this slide shows is 3 studies that looked at their patients who were newly diagnosed with HIV and looked to see how frequently they had sought care from a variety of different types over the years prior to diagnosis. And what this slide shows is that in these cohorts that people who are HIV infected, who are newly diagnosed, have frequently sought care, often in our emergency departments, in our urgent care clinics. Many of these people ultimately, when they get diagnosed, are diagnosed late in infection. So more rationale that our targeted testing has not been sufficient. Another point in terms of why we want to expand HIV screening is that at least a few years ago we estimated that of the just over slightly 1 million people who are HIV infected in the United States, about 21%, it was initially reported to be 25%, updated to be 21%. So people living with HIV, 21% are not yet aware that they're HIV infected, and the models estimate that over half of new infections come from this 21% who are unaware. So diagnosing people, getting them to know that they're HIV infected, getting them into care, but the other thing that diagnosing people does is people will automatically change their behavior to reduce the risk of transmitting to other people. And what this slide shows is just the range across different populations. Men who sex with men, sort of estimated just over half will reduce their behavior to some degree. And then again, in all men and in women and in injection drug users. So again, diagnosing people is prevention in itself because people will change their behavior to reduce transmission to other people. And then finally, we talk about, so we can't really afford it. This slide just is comparison of cost effectiveness across other things that we do for screening for disease prevention. And on top you see mammography, which is highly cost effective in women who are 50 to 69, less effective, cost effective in women to 40 to 49, which is to some degree why the recommendations changed not to screen this population that intensively. You see HPV vaccine in 12-year-old girls has just over $40,000 per quality adjusted life year saved. Colonoscopy, quite effective, though probably we're not implementing it as much as we should. But HIV screening in outpatients when your population has a prevalence of 1%, it costs $15,000 per quality adjusted life year saved, which is highly cost effective. Most, again, it's going to vary depending on what country you're in, but in the United States, we generally say that anything under $50,000 per quality is clearly cost effective and often under $100,000. So what you can see is even with a prevalence of 0.1%, that's 1 in 1,000, that HIV screening, again, that's one-time screening of everyone in healthcare settings, is cost effective. And that's why the CDC recommendations, again, from 2006, suggest that as long as you don't know that your prevalence in your population is under 1 in 1,000, that you should be doing routine screening. So after 2006, many states in the country changed their testing laws to align more closely with these recommendations. And what we have here is Washington's laws. On the next slide, I have Montana's laws. These were provided by the ATC, and I don't know sort of the other states that are represented here, Oregon and others, exactly how we can figure out how to reference that for you. Just know that all of the states have made it so that routine testing can occur, so that consent is no longer specifically required. The issue is that even though the laws have changed, that sometimes your hospitals or your clinics and your risk managers may have other rules. So please check with the people who really are responsible for you. But the state no longer the law is no longer a barrier to routine screening, and we're really trying to clarify this and make sure that at least in Washington State that the laws really allow people just to walk in and they get HIV tested essentially, if we could, as similar as they get screened for diabetes or hepatitis C. So that's why the CDC and why we in Washington and to you are promoting routine HIV screening. I want to take a few minutes now to talk about what the different HIV tests are, because gone are the days where we really only had one test. And now there are HIV tests that can screen not only for HIV antibodies, which is what we've traditionally done since the 1980s, but there is a test that is licensed to screen for HIV RNA. And recently there are now 2 tests that are licensed to screen it for HIV antibodies plus P24 antigen, these so-called 4th generation antibody and antigen combination tests. So in addition to, I'm not going to go into detail about what the standard blood tests are, but since, gosh, we're probably now 10 years into having rapid HIV tests. And this is a slide that came from Bernie Branson at the CDC that just shows a selection of what these rapid tests are. And they work very similarly to pregnancy tests in the most simple of cases, where you basically add your sample, add the sample to a buffer, and if you get a control line and a test line, then you have a positive test. If you have only a control line, you have a negative test. And several of these tests are licensed to be used at the point of care, so that they can be used at health fairs and in mobile vans and in other ways. There are some tests on here on this slide that are rapid tests that are only approved to be used in the laboratory. But as we sort of go year by year, there are more tests that are going to be available. And what is not on here is a test called INSTI that was recently FDA approved by Biolytical. That is a 1-minute test. So the standard tests take 20 minutes to complete. The test that is just approved is a 1-minute test. It's not yet CLIA waived, meaning it's not yet able to be used at the point of care, but they're in the process of doing the studies to be able to do that. So there are additional ways that you can get people tested that don't require blood draws. Although they're great in terms of getting people results and having someone walk in and be able to leave the clinic with a result in that day, one of the downsides of the rapid tests is that they're not as great in detecting someone who is recently infected. And so one of the things that this slide shows, you see a lot of names of a lot of different tests, and what it sadly I don't have ability to use a pointer, do I? So what you see on the right of this slide, OraQuick, Unigold in green are, that's okay, don't worry about it, are two of our most commonly used rapid tests. The Diagnostic HIV-1 right next to it in yellow is a first-generation test. The first-generation test, thank you, we told people would have window periods of 6 weeks, 3 months, sometimes even up to 6 months. And again, the window period is the time between when someone first is infected to when their test becomes positive. So what you see in green is that the rapid tests that we're most commonly using have one of the longer window periods. And as you move towards the left, you see the second generation antibody tests. The two tests in blue are tests that are rapid tests but only approved for use in the lab. And as you get farther left, you get into third generation antibody tests. And finally, the quickest test, the test with the shortest window period, is of course the RNA test. And I think my next slide explains that. Why is that after someone gets infected, actually, can I?
Yeah.
Thank you. So after someone gets infected, which is day 0 here, what you see, the first thing showing up is HIV RNA. And HIV RNA can be detected about 10 days to 2 weeks after someone gets HIV infected. And it's around this time when HIV levels get to 1 million, 10 million, I've seen 100 million copies before. It's around this time that people will have symptoms, this acute illness associated with the antiretroviral syndrome, which we'll talk about in 2 seconds. Help. But the next thing, sorry, didn't mean to do that. What you see in red is that antibodies don't actually appear for several weeks. And again, it will depend on the type of antibody test that you're using. So our best antibody detection will detect it about 3 weeks. And again, the rapid test probably about 1 to 2 months. But the thing that's important is that when people come in with these symptoms of acute HIV, so fever, fatigue, sore throat, muscle aches, joint aches, night sweats, headache, diarrhea, rash, often described as a flu-like illness, that antibody test may be negative, and you have to specifically order a test that's going to look for the virus. Traditionally, that's been an HIV RNA test. And it's about at least a half of people who acquire HIV will have these symptoms. What you see on the right in that is a wallet card of a campaign that we did here in Seattle trying to teach HIV-negative men who have sex with men the signs and symptoms so that they could come into our sites that are routinely doing HIV RNA testing. Since we've been doing pooled HIV RNA testing here in Seattle since 2003 routinely for this population. So I mentioned that we traditionally had to do antibody test and HIV RNA testing in order to detect acute HIV infection. And what's been really exciting over the last year or two has been the availability of these so-called 4th generation antigen antibody assays. And these antigen assays, the antigen part of it detects the P24 antigen, which appears probably 2 to 3 days after HIV RNA, but it appears well before, probably a week or 2 before the antibody detection systems. And so what you see on this slide are 3 studies that looked at our populations with acute HIV infection and looked at if we didn't do HIV RNA testing in these populations, but we just did this antigen-antibody combination assay, which if I back up a second and tell you, it's as easy to do as your standard antibody test. It can be automated. Its results can be available within the next day. So it really provides an advantage, plus it's much cheaper than HIV RNA testing, really provides an advantage over what we've traditionally been doing for people when we suspect acute HIV infection. And so on this slide in these 3 studies, what you can see is we probably, with the antigen component, can detect about at least 80%, close to 100% of all of our patients who are coming in with acute HIV infection, who you would miss if you only did antibody testing, but who we would catch with these newer assays. And the studies suggest that the people who we would miss with antigen testing often have HIV RNA levels of less than 15 to 30,000. So they're on the upswing of when their viral load hasn't yet reached peak. So just a quick slide about what the future holds. So I currently told you where we are, promoting routine testing, lots of new tests, is that I've already told you about INSTI number 2 on here, which is that 1-minute test, currently FDA approved but not yet available for point of care. Home HIV testing. It's an exciting thing that I'm working on. So we've always had home access. It's been approved since 1996. It allows people, you can buy a test in your pharmacy. Unfortunately, it costs about $40 to $60. But you can take it home, do a finger stick on yourself, do a dry blood spot, send it into a company and call them, depending on how much you pay, either next day or within the next week for results. Been pretty accurate, and about 1% of the people who have been testing actually will test HIV infected, including many people who have never tested before. So what we currently have is OraSure, the company who makes OraQuick, which is an oral fluid-based rapid HIV test, has currently completed studies and submitted them for FDA evaluation to be able to market their oral fluid test in the pharmacy, just like a pregnancy test, so that people can go into the pharmacy. We don't know yet how much it's going to cost. They could go into the pharmacy and buy an HIV test and be able to test themselves at home. So you may see this home HIV testing come to your population in, who knows, next year or 2. Can't say more about that. And then finally, we talked a little bit about the lab-based 4th generation antigen antibody combination assays, and I showed you a little bit of that data. What we currently have under study is a test called Determine, made by Alere, which is a rapid HIV test. Again, just like a little dipstick that gives you a line for control, line for antibody, HIV antibody, and a line for HIV antigen. It's not going to be used at home, but it has the potential to have greater sensitivity, i.e. a shorter window period than all of our other rapid tests. Has that potential. We're still waiting to see how it works in trials, but you may see additional rapid tests, including much more sensitive rapid tests, coming in the future. And then finally, the reason why I talk about all of these HIV tests and all of the sort of sensitivity in the window period is that oftentimes we're called on to help interpret test results. So in the inpatient setting, our teams may order an HIV test, and sometimes things get confusing because one of the tests may be positive, but the confirmatory test may be negative, and how do we help guide our generalists to understand sort of what that test means in terms of whether or not it's a false positive screening test or whether it could be a test that's in the window period. So traditionally, ever since we've had HIV testing in the mid-1980s, we've done it the same way. HIV screening test, an EIA, plus HIV Western blot. If the Western blot is positive, you have HIV infection, likely. And there's been this push from the laboratorians to get rid of the Western blot because it takes a lot of time. It can be confusing, particularly in the setting of HIV-2. We don't talk a lot about HIV-2 because it's pretty uncommon in this country, mostly folks coming from West Africa. But there is a need, certainly in certain populations in this country, to be able to discriminate HIV-1 to HIV-2. So this is the new proposed HIV diagnostic algorithm that's
potentially to replace EIA plus Western blot. And the recommendation from the CDC and the American, I believe, Association of Public Health Laboratories is likely to be screen with the most sensitive test that you have, meaning the test with the shortest window period. If you have fourth generation testing, access to that, then screen with that. And what you can see on the right is that if that initially screening test, your most sensitive test, is negative, you can reassure someone, as long as they haven't had recent risk within the last couple weeks, that they are negative, that they do not have HIV infection. Obviously, if you have a high clinical suspicion, you should do a different test and do a test a second time. But without, in the general screening, just do one test. If that screening test is positive, you're going to move towards a discriminatory immunoassay, what used to be the Western blot. And what has been proposed has been to use one of the laboratory-based rapid tests called multi-spot that is able to discriminate between HIV-1 and HIV-2 much better than the Western blot, and is probably more sensitive, meaning it has a shorter window period than the Western blot. That follow-up test is positive, just like with the Western blot, we're going to consider them to be HIV-1 infected, and that you should refer them, if you're referring people, or you should initiate care and do CD4 and viral load. The joy of the multi-spot is that it can identify HIV-2, and so we can refer people for HIV-2 care. If you have that a confusing situation where your screening test, which includes antigen and antibody, if that's positive but your confirmatory test is negative, the proposal is to go to NAT, which is nucleic acid amplification testing, or HIV RNA testing, and if that is positive, you have someone with acute HIV infection who is antibody negative, likely to be acute HIV infection, antibody negative, RNA and antigen positive. And if they are negative, you might want to consider referring someone for nucleic acid amplification for HIV-2, which, as far as I know, is still a research test, or you can reassure someone who has little risk that they're not HIV infected. So this is still in proposal. I haven't heard any more in follow-up conversations about it, but just know that we may be changing from HIV screening EIA plus Western blot if positive to something that is slightly more complicated, that is going to take under consideration the fact that our tests have gotten much better than the Western blot in the last 15 or so years. So thank you very much for your time and your attention.
Great, thanks, Dr. Steckler. We'll open it up for questions for just a couple of minutes if there's anybody from the network.
Right, and so they have two different scopes, right? So the U.S. Preventative Services Task Force is charged with looking at the cost effectiveness of the data. And my understanding from their last evaluation of the data was that they felt that there was no additional benefit to routine screening compared to targeted testing. And my understanding is that they are supposed to be re-reviewing the data this year. The CDC, of course, is charged with something different. They're charged with the public health and sort of saying, yes, we've done a decent job, but we still have a problem. People are being diagnosed late. People are still approaching care and not getting diagnosed, and so we need to take a different strategy, and that was the proposal, was to go to routine testing. So part of it is the different scopes of
Any other questions from the network?
There you go. I think we need to go. It's 25 after.
Yeah. Thank you so much, Dr. Steckler. That was great.
Sorry.
And I think she's going to step out while we move on to cases. But actually, real first, let's go around and do a real quick roll call. If you could just say who you are and who else is in the room with you. We'll start with Pocatello.
Hi, Dave. I got Dr. Dylan Cole, Lee Abrzewski, and Jackie Foster with us.
Jackie Foster off camera, I take it. Yeah.
Yes.
Okay. Great. And then in Boise,
Hi, Marvin, Alviso, and Clay's on the phone right now, actually. So.
okay, great. Medford, Oregon, looks like we got George Schultz. Anybody with you, George?
Nope, just here by myself. Good to be here.
Okay, good to see you. How about Anchorage, Alaska? Who's up there in Anchorage?
It's on. Hi, Sharon Zanman-Zeman, and I've got Hope Southshore with me as PA.
Great, welcome. And let's see, in Butte, Aaron Reese. I was just there yesterday. It's good to see you online. Anybody with you, Aaron?
Nope, I'm all by myself today.
Okay, great. And then up to Twin Falls.
Yeah, Christina Marchand, resident in Twin Falls. Just by myself.
Good to see you.
Thanks.
Who is next there? Do we have anybody on from Springfield, Oregon? Looks like maybe not. Okay, in Bozeman, Dr. Winton.
Just me.
Okay, good. Good to see you online. And who else? And in Spokane, Debbie, who do you have with you over there at Spokane?
I'll let them introduce themselves. It's two residents.
I'm Aparna Padmaraju, second year resident.
David Peak, intern.
Okay, welcome. And I think I hit everybody online. Is there anybody on the phone that's joining us as well? Don't think so? Okay, and we've got several others via Adobe, but we'll just have, if you're on Adobe, if you could just type in your text box and your chat box who you are and how many people are with you. And so I think we'll move right into cases with that. So Dr. Cole, are you ready to present over in Pocatello?
Yes.
Okay.
So yeah, first off, just thanks to everybody for allowing us to prioritize this patient, get her in right now. We had some timely questions about her management, so it's nice to be able to talk about her today.
Sure.
In any case, the just sort of framework for her, the kind of we're at a point of
Hold on one sec there, Dr. Cole. We lost your audio. 1 second. Okay. Make sure you're unmuted over there.
Are you hearing me now?
There we go.
Yes.
Okay.
Microphone is on. Yes. Okay. That could have been the
Okay.
Good. Okay. So I was just creating a little framework here that we have a couple clinical questions on her in terms of some new resistance that we've got with the recent genotype and direction on antiretrovirals that was timely to be able to talk about today. So in any case, this is a new patient to our clinic, and she is a 34-year-old patient who was initially diagnosed HIV positive back in 1997. At that time, that she was diagnosed a few days after the birth of her first child, and apparently had not been tested throughout that pregnancy. But as I understand it, it may have been in some peripartum testing that they came up with her status as being HIV positive. So in any case, they of course tested the child, and the child was negative and has remained so. She is in a monogamous heterosexual relationship and married to her husband that she's been with for ever since that diagnosis. And from a risk factor point of view, had some multiple partner heterosexual unprotected intercourse in those years just before her initial diagnosis, but never any other higher risk type of behaviors. In any case, as I said, she was diagnosed in 97. She's been with her same husband since that time, and in the meantime, they've had 2 more children, and at those times, she was on antiretroviral therapy throughout those pregnancies, and the rest of her family, including her husband, remains HIV negative. On that note, they do use condoms, but just as I met her just for the first visit the other day and was talking about those sorts of behaviors with her and whatnot, sounds like it's actually less than half of the time that they will use condoms, and they are in that monogamous heterosexual relationship, but not really using any other form of prevention. In any case, to give a sort of a snapshot on her treatment history, she is aware that she's been, in the years between 97 and 2010, had been tried on a few different antiviral regimens with history of some spotty compliance, kind of up and down, and she's really unclear. She knows that at times her viral load was well suppressed, but she isn't really able to give me the sorts of histories as far as what were her regimens during those years, or whether she had any true resistance noted on any testing at that time. Since 2010, we do have good records on her. She established care with a provider in the Twin Cities in Minnesota, and we have the records from that clinic sent over to us in the meantime. In January of 2010, she was started on Atripla, and that's really what she's been on since. Her viral load, or her CD4, when she was first started on Atripla, was right around 217. She rebounded, or she recovered well. Her viral load, which was, I think, several hundred thousand, went down to undetectable within 5 months after starting Atripla, and her CD4 count recovered to over 400. She moved to Pocatello a little over a year ago, and in this past year hasn't been seen by anyone and hasn't had any ongoing care. She's been getting her Atripla sent to her from her provider in the Twin Cities still, and has continued for the most part to take that, although she does seem to struggle with some depression and secondarily some on and off compliance with the medication. So in the past year, she really describes a couple months periods of time where she didn't take her medicine at all, and then she would start to take it again. Since she first contacted us, and we've done some initial genotyping and whatnot, just to let you know where she is now, her CD4 count now is actually 168, and her viral load is greater than 50,000. So again, this, as far as we know, is the first time that she's had a CD4 count under 200. But again, there's some of that history in the initial decade or so of her diagnosis that I don't actually have. Otherwise, as I said, 34-year-old woman. She remains free of any sort of opportunistic infections and has never had any of that, as well as has a really good bill of health aside from the HIV diagnosis. And I just met her for the first time in clinic a few days ago, and on physical exam, and in talking to her further about her general health and whatnot, she really no concerns there. From the point of view of her women's health screening, she